Public health is a population-based field of science focused on preventing disease and promoting health. Every week, we will be engaging in interactive discussions and analyses of the latest public health issues affecting you and your communities all around the world. This is the Public Health Insight Podcast.
My name is Gordon, and I'm joined by Ben, Sully, LaShawn, and a special guest who will be introduced later.
Before we move on, it is important to note that the views expressed in this podcast are our own and do not represent any of the organizations we work for or are affiliated with.
Institutional racism has permeated social, political, and economic institutions in North America for centuries. Criminal justice system and law enforcement are just a few examples that have been spotlighted recently. However, it is important to recognize that racism also exists in systems like education and healthcare. Institutional racism has contributed to the observed health disparities in racial and ethnic minorities in communities across the world. An article titled Cultural Competence in Healthcare: Is It Important for People with Chronic Conditions by Georgetown University's Health Policy Institute raises the issue that the burden of chronic disease is disproportionately distributed to racial and ethnic minorities in the United States. They also make the argument that there is a need to integrate cultural competence in healthcare practice to appropriately address the health needs of a population that's growing even more diverse. To help spark this informative conversation, we've invited a special guest. She's an experienced public health researcher working at the intersection of health equity and individual health empowerment. She uses her unique background in social work and health research to emphasize the importance of culturally appropriate health strategies and message dissemination. She has worked as a contractor in public health, supporting several public health-focused federal and state agencies. She is the founder of Focused Health Collective, an LLC where she works with organizations to enhance their research and communication strategies. In her free time, she enjoys spending time with family and friends, exploring new restaurants in the District of Columbia. She was also part of her two-part State of the Union Roundtable series on racism, the Black experience, and the perpetual fight for equality. Please welcome back our colleague, Rose Marcelin. Woo!
Welcome back, Rose.
I feel like I need a clap.
Oh, they're going to be clapping, all right. They're going to be clapping. So once again, thanks for all those contributions you made to our last two podcast episodes. I hope everyone who's listening now will go back and check those out. So thank you again.
Thank you so much for having me back, guys. Appreciate it.
All right. So in episode 13, we touched on the distinctions between healthcare systems, public health systems, and the all-encompassing health system. So for this discussion, we'll be focusing more on the healthcare system per se. But before we talk about, cultural competence in healthcare, let's briefly highlight some of the similarities of the healthcare systems that exist in Canada and the United States. So there's four of us on here from Canada and one from the United States. So what kind of things are important for people to know about the different healthcare systems?
Just thinking offhand, I know Canada has kind of a universal healthcare system, right? And so we definitely don't have that here. We have private payer systems, and then public systems as well, and then state-funded or government-funded systems here. So your private payers is usually when you have some kind of private health insurance. And then we have state-funded and government-funded systems like Medicare, Medicaid, that you can qualify for depending on certain statuses like your income or age. But I know you guys do it a little bit different, right?
Right. I'll just add, from what I understand, Rose, the other than Medicare and Medicaid, anyone that falls outside of that must purchase private insurance through their employer or through whatever market there is for healthcare coverage. Okay.
Right. So essentially, you'll get it you'll buy into it from your employer, or you can purchase individual insurance or family insurance through a third party, which is the direct source itself. A lot of hospitals and healthcare systems sometimes offer a sliding paying scale if you don't have either private insurance or Medicaid, Medicare. And that's kind of based on your income. So if you're low income or whatever your jurisdiction considers to be low income, you can essentially pay a lower fee for service. But that's usually the main buckets. And then within even the private payer, there's a lot of, different options, paid plans, HMOs, PPOs. It really gets into the nitty gritty. And even I in public health have to always read the little manual when it's time to sign up for health insurance at work to make sure I'm getting or trying to understand, what is going to work best for me, considering I'm a single person as opposed to, a colleague who might have a family and somebody might have a chronic health condition. They see the doctor more often. So there's so many options, honestly, to choose from.
It's interesting. It sounds like you have to be, so in order to get the right private plan, you kind of have to be aware of what your health risks and stuff are in order to make the best decisions, right?
Yeah, absolutely. And I think that's definitely what you said is important. I think having a public health background certainly helps because I understand the difference between the basic difference between the HMO and a PPO, but sometimes, you don't know. And so you have to kind of understand what that means for you and knowing whether or not your plan comes with a deductible and what the deductible is, how much it is that you're getting, and what does that mean for you. I know for me, for instance, when I first came out of school and I got a job, I bought into the insurance plan and not really understanding what anything really meant. I just knew, oh my God, I have health insurance. If something would happen to me, I'm good, which is not necessarily what it means. Just going to like a regular doctor's visit before what people call Obamacare Act in 2010 passed, I still had to pay a copay for annual checkup visit. Now, essentially, you don't have to pay for that. It's covered under the act. But I didn't understand that, what is the copay? I actually have to pay to go see somebody. Or if you get a test, you still have to pay that out-of-pocket fee that goes into your deductible. So it's a very complex system. And even I, who is relatively familiar with healthcare, sometimes I get a bill in the mail and I'm like, for what? And I have to go back and pull out the handbook and say, okay, that wasn't covered in this, whole categories of things that are covered. It's the one thing that's not covered, and then you get a bill for that. So I don't know if it's that complex for you guys.
No, definitely not. I was just gonna say, just listening to you, just so overwhelming. Is my big toe gonna be covered? Maybe my left and right toe won't be. Like that's a lot to take.
Sounds like fine print to me.
Yeah,
it's definitely fine print. It's definitely fine print.
Oh, man.
And even if it's not fine print, it's print that people assume or it's kind of like, this is common sense, but it's really not. You think you buy health insurance, you're going to be covered, but there's so many restrictions depending on what plan you have. I have a plan under one of the big providers, Blue Cross Blue Shield, but the one I bought into specifically is really for the DMV, DC, Maryland, Virginia area. So if I'm here in Florida, if something were to happen to me, I'll be covered, but then I'll technically be out of network, and there's a different fee associated with being out of network, even though I have insurance. So it's a lot. It's super complex here, and that's the can of worms in and of itself.
Yeah, in Canada, though, just to simplify it, we have the Canada Health Act. As you said, it's publicly funded, privately delivered, and essentially most healthcare services that Canadians or anyone with a health card from their province, they wouldn't be expected to pay anything at the point of healthcare delivery. In saying that, though, there are a few things that aren't covered, and the provinces. Well, we'll get to that. But there's a few things that aren't covered in terms of medical procedures or certain lab tests. So not every single thing is covered. But if you are in need of treatment of some kind and you do go to seek healthcare, that in of itself will not be, you can't bill that to the patient. And that's part of why a lot of Canadians are proud about the healthcare system, but that doesn't go to say our system is perfect either.
Mm-hmm. Right. Yeah, and even if we consider Canada as a geographic landmass, we see that a lot of the population is concentrated towards the bottom of the country, like the major cities like Toronto.
And urban centers.
Yeah, and urban centers. But if you look up north, you see many rural communities, and they may not have, even though we have universal healthcare, the access to that is a different story.
Mm-hmm.
Exactly.
Right.
Yeah.
So affordable, but sometimes not accessible.
I gotcha.
Mm-hmm.
Yeah, and it kind of
Affordable is good though.
Yeah.
Right.
Yeah, it's good. It's good for sure.
Yeah.
There's also like another nuance to accessibility though, because the fact that it's so available means that you're often in long lineups to even get an appointment. Like for example, when you're looking at an MRI, you're looking at least 3 months.
Oh wow.
Is that really accessible?
Right. So it's one of the kind of double-edged sword of, if you're trying to make a healthcare system that emphasizes equality, then no matter what your status in life is, you're going to wait the same time for diagnosis and treatment. So what the system tries to do is discourage kind of two-tier medicine, where the richer people can have better privatized healthcare, and then the resources get shifted there, and then the people who aren't able to afford get lower quality healthcare. So this is the price essentially that we pay. Not to say that it's not, it can't be better, because there are some provinces like Saskatchewan who do have lower wait times than the Canadian average. Mm-hmm. So there's room for improvement.
Yeah, it kind of brings me back to what we were taught in our MPH program. At a very basic level, there's always going to be a trade-off between accessibility, price, and quality when it comes to the healthcare.
Always.
Yeah. So we're establishing the context of the two healthcare systems, an important metric of how a healthcare system performs is essentially the percentage of GDP that's spent on healthcare. So in Canada, about 10% of our GDP is spent on healthcare, compared to the United States, which is 17%. And you might think, well, I think anyway, it looks a little counterintuitive, because if healthcare in Canada is publicly funded, wouldn't you expect that the government would spend more money as a percentage of GDP rather than a place where healthcare is more privatized?
So I think at face value, the numbers don't sound too far off. However, I know here we do talk about that 17% as it being an extremely high number. I think part of it is when we think about healthcare expenditures, so much of that is accounted for at later in life. There's a lot of costs associated as you get older with medical care, and so many different factors go into it. But if you think about just here in general, just how expensive healthcare is, it's a money-making system. There's a fee associated with just about anything when it comes to healthcare here. So from the 911 call, you pay for the ambulance to the hospital. If you have to, God forbid, they have to call a helicopter or something, that's a humongous bill that's not necessarily covered by insurance. And then when you get to the hospital, depending on what hospital you go to, things are covered, things are not covered. You pay for your, anesthesiologist bill, you get a surgery bill, you get the hospital bill, you get the admin bill. It's compacted the way our system is set up, that it is, if you have some kind of health emergency, it can cripple a family. Some families have to file for bankruptcy just to pay for the hospital bill. And then you think about other things that are, life-saving treatment for certain people that, they can't afford to pay for it, or it's just so expensive, even with insurance, what families have to pay for certain things. So I know for us here, when we talk about the cost of, healthcare, and now there was this, talk of Medicare for all, Medicaid for all, and the hopes that, this will not just challenge us to think about healthcare, but to really transform the way healthcare is delivered here in the States, to move towards more of a, Canadian system, Canadian-like system when everyone has, free and accessible healthcare.
Right.
However, to change that, will require essentially starting from the bottom up, because the system is not meant for that. It's built, to be paid at every step along the way.
Yeah. I think even you mentioned it, Rose. A lot of people may not be able to even afford the healthcare to begin with. But for me, that 17% I think is especially highlighted when you take it into the global context, looking at OECD countries and looking at the U.S. That 17% is amongst the highest in terms of spending per person, right? And if we, for example, compare that to Canada, which actually spends less per person, we in Canada, about half. So in Canada, we actually see that the life expectancy is around 4 years higher than the US, and things like indicators such as maternal mortality rate is 4 times lower than the US. So I think when you take it into context globally, I think that's the reason why some people may focus on these numbers, like the 17%.
I was doing some reading, Rose, and maybe you've seen this in your line of work or people that you know, and apparently more than 500,000 people go into bankruptcy every year because of medical bills and healthcare bills.
Oh yeah, it's astronomical. It's astronomical what a medical bill will do to some people, and to some people, I think I'll put myself in that category. Because while your insurance, let's say your out of pocket or your deductible is $2,500, so your insurance would kick in essentially after anything over $2,500. But within that, there's all the fine print. Like it might cover this, but not this. It might cover a percentage of this, but not that other remaining percentage. And that bill comes out to be thousands of dollars. And for a lot of families, a lot of people, that out of pocket bill for, if you think about like cancer treatment and how expensive that is, families will file for bankruptcy because they just simply cannot afford to pay. And actually, the New York Times has a podcast called The Daily. I'll try to remember the episode name, but it was a couple of weeks, probably pre-COVID, I think it was. They do a series on medical bills and what that looks like for a person. And this lady, she's, a working mom, and I think her daughter had to have some kind of medical procedure, but they talk about how that has impacted her life and her inability to pay. She's on a payment plan with the hospital, to the point that if you don't pay, you risk going to jail. It's a whole thing. Like it's people don't think about what that bill, the real bill, looks like, because we, are not in those situations. But I always imagine if you get a bill in the mail for $17,000, what are you gonna do?
Wow. Yeah.
If you don't have $17,000 to write a check, and you know what I mean, and then you're involved with, they get the courts involved and they'll put a lien, and it's a whole process, and it's a very expensive process. While we have insurance, a lot of people here in the States are what we call underinsured, where they might have insurance, but the kind of coverage they have is very limited. Very limited, so
doesn't
that
meet their needs.
Exactly, and if anything falls outside of the purview, you're stuck footing that bill where you think, oh, I have insurance, it'll pay for it, but in reality, no, what you have doesn't cover this.
So, out-of-pocket spending per person in Canada is about half of what it is in the United States. So, and that's what I was getting at earlier. The U.S. spends a higher percentage of their GDP on healthcare than Canada, but yet Canadians spend half of what the Americans spend out of pocket, and then the life expectancy is higher and a bunch of different health outcomes are higher. And what this tells me, and I don't mean to ramble on, this tells me that there's potentially more inefficiencies in the way the United States uses their money to fund healthcare. And it potentially tells me there's a lot of maybe unregulated or disparities in healthcare quality delivery that account for some of this variance as well. That's what that tells me.
Yeah, I think you hit it on the head when you talk about some of the discrepancies in healthcare here in the States, even access. I think you guys alluded to it with some of the rural areas in Canada, but even in metropolitan areas, there's still access issues to healthcare. And then there's issues that come with adhering and complying to doctors, orders essentially. If you have a prescription and you have to go fill it, there's issues with, just cost of the prescription and what that looks like for someone. Or maybe if someone is trying to manage a chronic condition, it's not just simply, oh, let me go see my doctor. It's a lot for them to get to that appointment. And then the adherence piece, can be a lot for one person to manage. So I think what's not accounted for in those numbers are all the nuances and disparities, that underpin our healthcare system. But there's so many social issues that I think, drive those numbers. When you talk about like maternal health, like there's so many issues behind that count too. That may not be necessarily reflected by just looking at a percentage.
Yeah, one more point too to add to that. And just thinking, this has me thinking a lot, and I know you guys love when I think. So this also potentially tells me, because as you mentioned, Rose, Medicare is for seniors 65 and older, correct? Okay.
Correct.
So that tells me, and given that the life expectancy is about 4 years lower, this potentially tells me a lot of money is being spent in the Medicare plan because those aging seniors potentially have more complex health needs than their counterparts in Canada. Maybe because the disparities are worse, or maybe there's other things in the social context that exacerbate things. Because, when we say percentage of GDP spending, what are we talking about? And we've established that the government funds Medicare, so maybe the dollars are going there because there's a lot of things upstream that weren't prevented.
Remember, public health is a field of inquiry and an arena for action to improve lives one population at a time. This has been the Public Health Insight Podcast. If you've enjoyed this episode, please drop us a like and follow us on Spotify, Apple Podcast, Google Podcast, or your podcast platform of choice. You can also send us your questions, comments, and suggestions for discussion topics at thepublichealthinsight@gmail.com. Thank you for listening, and we'll see you in the next episode.